back to ACCEL for May 2016. I'm Alfred Beauvais. Disc 2 begins with a talk Verheugt had with Dr. Kirk Garratt, Associate Director of the Center for Heart and Vascular Health at ChristianaCare Health Center in Newark, Delaware. They cover messages from the dual antiplatelet, or the DAPT study. What do I need to know?
Kirk, welcome. Can you give in a few sentences the messages you gave to the audience?
Great to be here with you. Everyone knows the DAPT trial by now, the largest and still the only powered trial to test the value of dual antiplatelet therapy prolonged beyond 12 months for patients receiving coronary stents. Powered, I say, for both the composite of adverse clinical events as well as stent thrombosis. And it's well known now that the results of that trial demonstrated that prolonging dual antiplatelet therapy with either clopidogrel or prasugrel results in an important reduction in ischemic events out at 30 and 33 months after stent placement. The unfortunate side of this, of course, is that the prolonged exposure to dual antiplatelet therapy, as would have been expected, did come with a cost of additional bleeding and absolute risk of increased bleeding measured using the Gusto yardstick, Gusto severe or moderate bleeding, of about 1%. My talk recently was focused on the ACS publication. We had an opportunity to assess that subpopulation out of the DAPT trial. Robert Ye had a nice publication earlier this year.
Wasn't it?
Yeah. And what we found was interesting. First, the overall findings of the DAPT trial, as had been expected, applied to the ACS population. That is, for that subgroup, we saw reduced ischemic events with increased bleeding with prolonged therapy. Also, what was expected was that the absolute rate of adverse events was higher among the ACS population. Well, no surprise. We've seen this before. What was a little surprising were two things. First, the absolute risk reduction compared to the control group for the ACS population was actually magnified with regard to the composite of major adverse cardiac and cerebrovascular events. So there was greater risk reduction for that subpopulation compared to the non-ACS population. Now, when this was tested with an interaction test, it just fell short of meeting significance with a p-value of 0.06. So we have to conclude that there's roughly equivalent benefit for the two subgroups, but I think anyone looking at the data would conclude that this is a special group, probably will stand to extract the most benefit out of a prolonged antiplatelet treatment.
Yeah, but that's understandable because a patient with prior ACS or ACS as the entry into the trial had a thrombotic event, right?
Correct.
Where in non-ACS patients, elective cases, if you wish to say that, they usually have had no thrombotic complication in their coronaries and therefore will have less benefit in the same harm.
Right. So the ACS group has been long recognized as having increased thrombotic risk in the short term after treatment, for sure. Yeah. I think the new information out of the DAPT trial was that the DAPT study suggests that, in fact, that added risk will persist even longer, beyond 12 months after their index treatment, and so the benefit of therapy will be increased in that cohort.
Yeah, and that says also about patients that they are prone to thrombosis also after the first event, despite aspirin.
Yeah.
So aspirin, it's a weak antiplatelet drug, but it had magnificent action in the acute phase of ACS. We know that from the ICES-2 trial, the study by Lars Valentin. But on the long term, it may be not so effective. And then you need more antiplatelet therapy like clopidogrel or even prasugrel or even ticagrelor. And that is, I think, also for doctors who see patients after elective PCI. As you know, the European guidelines say you may stop maybe at 6 months, even with the drug-eluting stent. Mm-hmm. And if you prolong treatment in this non-thrombotic PCI population, the benefits are less outspoken, although it didn't reach statistical significance. And also the mortality in that group was, I think, not so different. I think
it may be going in the wrong direction.
In the wrong direction for elective cases. For ACS it was not so clear, but maybe we should especially focus on the post-ACS patients who got stented for a longer duration of therapy.
Yeah, so there's a couple of interesting things in there, of course. With regard to the thrombotic risk, as I said earlier, I think one of the lessons out of the DAPT study is that this trial confirms that those patients are indeed at increased risk, not just in the short term, but in the longer term.
Thrombosis, yeah.
And importantly, the risk reduction seen in the DAPT study and seen also in trials like the Pegasus study, for example, was all tied up in an infarct reduction. The risk of infarct went down. Other elements of the composite clinical endpoint did not differ significantly. And what's interesting is two things. Number one, the risk of that going down for the ACS population was greater than for the non-ACS population, consistent with what we've discussed. But you would hope that if there was an important reduction in myocardial infarction, it might give you some signal of benefit with regard to mortality.
Yeah.
We didn't see it. Now, why didn't we see it? Well, no one knows the answer to that, of course, but I can tell you what the data suggests. The data suggests that, in fact, the difference in mortality between the two cohorts, long and short dual antiplatelet therapy groups, was not in cardiovascular death. It was in non-cardiovascular death. Well, that's curious, right?
Yeah.
And so what do we know about that group? Well, we know that the majority of patients who died of non-cardiovascular causes died of complications related to malignancy.
Yeah.
Now, it turned out that there was a slight but possibly important imbalance in the number of patients who are known to have malignancies going into the DAPT study. As you know, for the overall cohort, the difference in overall mortality got very, very close to being statistically important with a p-value 0.055 at 30 months. Then at 33 months, it made the grade as being important. When you, though, took out the patients who were known to have cancer going in at the time of enrollment and randomization, that faded away. It's perhaps a weak argument against a direct causal effect, but it's something. More importantly, an important meta-analysis I'm sure you saw published in Lancet on the heels of the DAPT study last fall found that for the composite of something like 70,000 patients in a number of different trials, no convincing signal of increased death with prolonged dual antiplatelet therapy
No
exposure.
reduction either.
But no reduction either. So now you have to ask, well, what's going on there?
Yeah.
There's no biologically plausible explanation that I can come up with, frankly. You would anticipate that reductions in ischemic events would lead to some signal of improved mortality unless there's a bleeding offset. Let's explore that. We know that the risk of bleeding with prolonged therapy for the overall cohort in DAPT was about 1% higher. Overall absolute risk, increased risk of moderate and severe bleeding, about 1%. The majority of that, though, was only moderate bleeding, not the type of bleeding that you would expect to drive mortality, but it's something.
Yeah, but maybe the observation we do in many trials now that bleeding is associated with mortality. The patients don't bleed to death, it is very rare, but there is something in patients that bleed that increase their mortality. And we do not know the exact mechanism. And in fact, in Pegasus, we saw the same. A big study, at least double as big as DAPT.
Yeah.
ACS population only, because you could only enter into Pegasus after a sustained MI 1 to 3 years earlier. And it was effective, a reduction in MI, reduction in stroke, but no reduction in mortality. Maybe a little bit of a lower dose, a little bit. That was not significant, but the regular dose, the 90 milligrams BID, no difference in mortality.
And the bleeding in Pegasus, I believe, was a little higher than in the DAPT
Absolutely.
study. So still, Garg and colleagues had a very nice paper a couple of years ago in the American Journal of Cardiology, wherein they tried to estimate how much ischemic event reduction would sufficiently offset an increased risk of bleeding using quality-adjusted life years. A very nice independent paper. I like this study a lot. If you use the conclusions that come out of that paper to help you judge the merit of both Pegasus and the DAPT study, you will conclude that the reduction in ischemic events is more than sufficient to accept the increased bleeding risk.
Can you give, as a last answer to my questions, some ideas how to prevent bleeding when a patient needs dual antiplatelet therapy for a longer period of time? Can you give some advice to our listeners?
Well, I guess there's two sides to that coin. The first is for those patients who need therapy regardless of their bleeding risk. That is, you determine that this is someone with special need, a left main stent or something that you're compelled to treat. For those patients, we have limited ability to contain their risk. Remember that the majority of these bleeds are gastrointestinal, so proton pump inhibitors and the like are of value. We know that they can be used safely together with clopidogrel and prasugrel and ticagrelor. So that's something to be done. But remember that there are still many, many bleeds that are not gastrointestinal, and we have limited ability to control that. The other side of the coin would be that if you have a patient in whom you've completed that mandatory period of dual antiplatelet therapy, a thorough assessment of both their ischemic and bleeding risk is the necessary and required move at that point. That's the strongest act you can take as a clinician to help balance the bleeding risk and the ischemic benefit.
And drop aspirin?
Stop aspirin?
Yeah. The trials are running, so we cannot answer
we
this.
can't answer it yet. I love the idea, and I'm hoping that the trials are positive, because this is what my gut tells me is the right move. Yeah. But today, I don't think we can make that recommendation.
Thank you very much, Kirk, for coming and giving this excellent interview.
It's been a pleasure.